Okay, thank you. So the study we did was on timing of the first prenatal ultrasound and what factors affect in 3 teaching hospitals in Addis Ababa. This is the outline of my presentation. So I will start with introduction. As a well-known fact, antenatal care is one of the proven tool to decrease fetal maternal mortality and morbidity. And it's one of the key objective of antenatal care, which is to detect conditions that adversely affect the fetal maternal health as early as possible in pregnancy. And of the various evaluations that are done in pregnancy, obstetric ultrasound is just one of the key evaluations. And in contemporary obstetric practice, obstetric ultrasound is almost an extension of history and physical examination. Obstetric ultrasound has, of course, many different objectives at different times of the pregnancy. Obstetric ultrasound, which is done in the first trimester, have many advantages like determining the number of fetus, the gestational age, and whether the fetus is viable or not, and of course for dating purpose. And as already known, dating the pregnancy has multiple advantages, like decreasing the likelihood of induction for postpartum pregnancy and early milestone, which is very important in the management of the pregnancy. Obstetric ultrasound, which is done in the second trimester, has multiple advantage, one of which is documenting fetal anatomy and diagnosing congenital anomalies that may affect the obstetric management of the pregnancy. The presence of major anomalies in the fetus should be identified as early as possible in pregnancy, because that information would seriously affect the obstetric management of the pregnancy. And the late the diagnosis is made, the difficult is the obstetric management of the pregnancy. And if at all there is a congenital anomaly diagnosed which is incompatible with life, and if termination of the pregnancy is to be decided, it's much more complicated to do that in the third trimester than in the first and early second trimester. And of course, the ethical and legal dilemma is also of paramount if the anomaly is diagnosed late in the course of the pregnancy, especially in countries like Ethiopia, where fetal and neonatal management of serious congenital anomalies is not that much well developed. So in resource-limited countries like Ethiopia, it's a daily finding to see lethal congenital anomalies at term, as serious as anencephaly, to be diagnosed late in the pregnancy in the third trimester, which these anomalies should have been diagnosed in the first or early second trimester. Different organizations have
Hello, Dr. Sisay, we can't hear you.
I think he has been lost.
Can you hear me?
Yeah, now we can hear you. You can proceed. Thank you.
Okay, thank you. So different organizations and countries have different recommendations on the practice of obstetric ultrasound. And in its latest recommendation, WHO recommends all pregnant women should have the first obstetric ultrasound before 24 weeks. So the problem we have identified before this study is because St. Paul Hospital is one of the busiest and largest hospitals in Ethiopia and in Addis Ababa, it's almost a common finding to see lethal anomalies in the third trimester and even at term. in remote areas of the country, pregnant women may not have access to routine obstetric ultrasound in the course of the pregnancy due to limited resources. But finding a lethal anomaly for the first time in the third trimester at term in Addis Ababa, where antenatal care service, including obstetric ultrasound, is free and readily accessible, is unacceptable. And obstetric ultrasound service is one of the readily available service in Addis Ababa and in most of the health institutions at government and health centers. It's done for free. And but even if it is free, some patients may not have obstetric ultrasound due to financial issues. What's more bothering is there are a lot of pregnant women with no obvious financial constraints who have their first obstetric ultrasound late in the course of the pregnancy. The regrettable end of this spectrum is having regular antenatal care and learning very late in the third trimester or at term that the fetus have lethal congenital anomaly due to very late first obstetric ultrasound. So finding the commonest time for the first obstetric ultrasound and what factors affect it are very important to identify interventions that are required to curb complications that arise from late first obstetric ultrasound. So we did some literature review, and there are only few studies done globally which directly assess this issue. And the only published study that we found was the study done in Canada, which had studied the timing for the first obstetric ultrasound. And other studies that we have found studied different issues like factors affecting the timing for first antenatal care visit and what factors affected the timing. So the only study which we found was a study done in Canada, which was published in 2019. This was a cross-sectional survey which revealed that only 68% of Canadian women received an optimally timed prenatal ultrasound, and like 4.3% received late ultrasound. So even in the Canadian study, significant numbers of women didn't have optimally timed first ultrasound. And the factors which affected this in the Canadian study were like the province of the prenatal care, the maternal age, the country of birth, and an interaction effect between the prenatal care provider and history of miscarriage. So there are other studies which studied the timing for first antenatal care, and this is the study which is done in Arba Minchikamogofa. Based on this study, only 14% of the respondents had their first ANC visit within the recommendation by WHO. And there are also multiple studies which showed different factors affecting, like 52% of the women in Addis Zaman Primary Hospital had late antenatal care initiation, and the factors which affected were being housewife, poor knowledge, and unplanned pregnancy. So this the fourth study which was done in Addis Ababa showed that only 42% of pregnant women had late antenatal care initiation. And the fifth study, which was done in Dilla town, showed 65% of pregnant women had late antenatal care. And the sixth study, which assessed the antenatal care utilization, in Ethiopia showed maternal education, income, and distance from health institutions affected the antenatal care utilization by pregnant women. And the seventh study showed 89% of pregnant women wanted to know if the baby had serious congenital or genetic abnormalities during pregnancy. So after reviewing these studies, we went to our research, and our research major objective was to identify the prevalence of optimally timed and late first obstetric ultrasound. And the specific objective was to identify the most common time for the first obstetric ultrasound and to see what factors affect the first obstetric ultrasound. And we did a cross-sectional survey at 3 teaching hospitals in Addis Ababa, which were St. Paul, Ras Desta, and Minilik II Memorial Hospitals. And using a single proportion formula, 385 pregnant mothers sample size was calculated, and convenience sampling was used until sample size was reached. And the variables were, of course, the dependent variable was timing of the first obstetric ultrasound, and the independent variable we assessed were age, marital status, address, monthly income, level of education, parity, place of first antenatal care, and history of major obstetric problem and health problem before pregnancy and health problem in this pregnancy. These were the independent variables that we have assessed. And all consenting pregnant mothers were included in the study. And these were the operational definitions we have used. We have defined optimally timed first obstetric ultrasound when the first prenatal ultrasound is done before 6 months based on the WHO recommendation. And we labeled late first obstetric ultrasound when the first prenatal ultrasound is done after 6 months of pregnancy. These were the operational definitions we have used. And the data was collected and analyzed, of course, after appropriate ethical and other procedures. So the results showed these were the general findings, like the mean age of respondents were 28 and 76% of the respondents were from Addis Ababa. The rest were from around Addis. And 88% of the pregnant women were married. And these are the socio-demographic characteristics of the study. And 40% of the pregnant mothers we have assessed were premi-gravids. And 48% of respondents had a known health problem before this pregnancy, and 57% had some form of health problem during this pregnancy. So from a multigravid woman, woman, 33% had main obstetric problem during this pregnancy, and 48% of the respondents started their antenatal care at health centers. Almost half of the pregnant women that we have studied at the 3 teaching hospitals, they started their antenatal care at health centers. So these are the obstetric characteristics of our population. And the mean gestational age for first prenatal ultrasound in this study were 4.5 months. 4.5 months, and the earliest time pregnant mothers had their first prenatal ultrasound is the first month, and the latest time was 8 months. And the mean gestational age for first antenatal care was at 3rd month. And the earliest time is, of course, the first month, and the latest time was the 7th month. And based on our operational definition, 67% of pregnant mothers had optimally timed first ultrasound. 67% of them had optimally timed first ultrasound. Like significant number, like 1/3 or 32% of pregnant mothers didn't have optimally timed first prenatal ultrasound. And this is the gestational age at first antenatal care. So as you can see, the mean gestational age is 3/3 months. Is the 3rd month, and gestational age at first obstetric ultrasound, as you can see here, is the 4.5 at 4th month is the mean gestational age. So this is the mean gestational age at first antenatal care and at first obstetric ultrasound. 3.1 months is for first antenatal care and 4.5 months is for first obstetric ultrasound. So this is the prevalence of optimally timed obstetric ultrasound, which showed 67% had optimally timed obstetric ultrasound. So what factors affected whether a woman have optimally timed first ultrasound? We have studied, and so the following socio-demographic factors have no relationship with optimally timed obstetric ultrasound. So the address of the woman, the marital status, the region, the level of education, the employment status, the monthly income didn't affect whether a woman have optimally timed ultrasound or not. And obstetric characteristics with no relationship to optimally timed ultrasound are parity of the woman, health problem before pregnancy, health problem during this pregnancy, whether the pregnancy is planned or not, and even time of the first antenatal care did not affect whether a woman have optimally timed ultrasound or not. Variables which significantly affected whether a woman can have optimally timed ultrasound or not are previous history of major obstetric problem during pregnancy and the place of the first antenatal care. These are the factors which significantly affected the time whether the woman would have optimally timed first prenatal ultrasound or not. This is the odds ratio. Now, the obstetric factor which significantly affected the timing of the first prenatal ultrasound is whether or not the woman had previous major obstetric problem. Now, 84% of pregnant women who had major obstetric problem in previous pregnancy had optimally timed first prenatal ultrasound. So, significant number of those with previous obstetric problem, they have optimally timed obstetric ultrasound in the next pregnancy. Those having previous major obstetric problem were 5.2 times more likely to have optimally timed ultrasound than mothers without major obstetric problem. This is the cross tabulation which showed what factors affected and the association. So having a previous major obstetric problem is one of the most important factors which determined whether the woman have optimally timed ultrasound in the next pregnancy, because as you can see, 84% of those with such a problem had optimally timed ultrasound in their next pregnancy, and of course the association is significant. So this is the binary logistic regression analysis for optimally timed ultrasound and previous major obstetric history. As you can see, there is a significant relationship with previous bad obstetric history. So from pregnant mothers, the other is of course the other is where the woman has started her antenatal care. And from pregnant mothers who started their antenatal care at health centers, almost half of them did not have optimally timed prenatal ultrasound. 48% didn't have optimally timed ultrasound. And those from private MCH private MCH centers, significant numbers, like 87% of them have optimally timed ultrasound, and 89% of those women who started antenatal care at government hospitals had optimally timed first prenatal ultrasound. So compared to those women who have started their antenatal care at health centers, those women who have started their antenatal care at private clinic were 1.7 times more likely to have optimally timed first prenatal ultrasound. So those mothers who had their first antenatal care at private hospital were, of course, 3.2 times more likely to have optimally first prenatal ultrasound. And those who had antenatal care at private health institution and government hospitals were much more likely to have optimally timed first prenatal ultrasound, with the following odds ratio. For government was 7, and for private MCH center was 4.9. So this is the table which shows the place of antenatal care versus optimally timed ultrasound. So as you can see here, those who have started antenatal care at health center, almost 48%, almost 50% of them do not have optimally timed ultrasound. And those who started at private clinic, private hospital, government hospital, and private MCH center, the numbers, the proportion is significantly higher. The highest being starting antenatal care at government hospital, where 89% of the pregnant mother had optimally timed first prenatal ultrasound. And this is the graph which shows the proportions that was already displayed in the table. And of course, the relationship between optimally timed first ultrasound and place of first antenatal care, the relationship is significant, with significant level in binary logistic regression and in multiple regression as well. In multiple logistic regression analysis as well, the relationship still continued, and previous bad obstetric history and the place where the woman started her first antenatal care were the only factors which affected whether the woman would have optimally timed obstetric ultrasound in this study. So when we see the findings, this study showed a significant number, 1/3 of pregnant women who have antenatal care in Addis Ababa do not have optimally timed ultrasound. This finding is similar to the Canadian study, but of course there are there is difference in operational definition. We have used WHO recommendation for the operational definition, and the Canadian study, they have used Society of Canadian Obstetrician and Gynecology recommendation for optimally timed first prenatal ultrasound, which defined an ultrasound done between 11 to 22 weeks as optimally timed ultrasound. And the WHO study, the WHO definition is more relevant in our case because most of our pregnant mothers do not remember the duration of the pregnancy in weeks, and most pregnant women use menses for dating pregnancy. So it was easier to define the duration of the pregnancy in menses for pregnant mothers so that they can remember at what month of the pregnancy was their first ultrasound done. The fact that 1/3 of the pregnant women do not have appropriately or optimally timed first prenatal ultrasound is concerning, because we are missing the golden opportunity for diagnosis of important fetal conditions, which significantly affect the obstetric management of the pregnancy. And this is the reason why we see many lethal anomalies in the third trimester. This is concerning because those mothers having antenatal care in Addis Ababa, where ultrasound service is widely available and it's given for free in most of the health centers. The proportion of mothers who have no optimally timed first ultrasound can be much higher outside Addis Ababa, where other issues came into place, like limited access to obstetric ultrasound. So what's the other study? The other finding this study has shown is there are pregnant mothers who have regular antenatal follow-up, but who do not have optimally timed first obstetric ultrasound. This is shown in this study because the mean gestational age for first antenatal care visit is 3 months, and the mean gestational age for first prenatal ultrasound is 4.5 months. And this study also found from mothers who started their antenatal care at second month, almost 25% have no optimally timed ultrasound. And for mothers who started antenatal care at third month, 18% do not have optimally timed ultrasound. The later the gestational age, the greater the numbers would be. And this study showed that having regular antenatal care is not a guarantee for optimally timed first prenatal ultrasound. So this is the most concerning part for policymakers, because the woman has shown up for antenatal care, she's booked for antenatal care, but her first obstetric ultrasound is not optimally timed. So unlike the Canadian study, where socio-demographic characteristics did affect the finding, in this study, socio-demographic characteristics did not affect the whether the woman would have optimally timed ultrasound or not. Like in the Canadian study, the address of the woman, the age of the woman, educational status of the woman, and monthly income of the woman had affected the whether a woman would have first antenatal care or not. In this study, these factors did not show significant relationship. And something to explain this, now SWORD has suggested socio-ecological model for determinants of healthcare service utilization. So what SWORD suggests is different socio-economic status would expose a woman for different personal, environmental, political, and other influencers, which ultimately lead to different health service utilization patterns. These factors may cancel out each other, and the finding at the end of the study can be unpredictable. For example, an older woman maybe is more likely to be educated and have many experience. So technically, that means she have more knowledge on the use of early antenatal care and early ultrasound, and she is more likely to utilize healthcare, to utilize more antenatal care. But at the same time, an older woman may have many uneventful pregnancies before, and because she has many uneventful pregnancies, this may make her not to seek early antenatal care and early ultrasound. So this socio-ecological model suggests that different factors affect the healthcare utilization pattern of the woman. So of the factors which significantly affected the timing is, of course, the place of the first antenatal care, where they have started. I have displayed the numbers. This might be due to the fact that in current healthcare systems in Ethiopia, at health centers, antenatal care is provided by midwives and physicians, especially gynecologists and obstetricians, are not generally working at health centers. So the non-gynecologist and obstetrician who provide antenatal care usually do not order ultrasound in the first trimester and in early second trimester. This might be due to a knowledge gap on the use of early prenatal ultrasound, or it might be due to high patient burden, and it might also be due to long waiting time at health centers, as most of the pregnant mothers start their antenatal care at health centers, as our data has also confirmed. This is supported by the fact that even significant number of those who have started their first antenatal care at third month have no optimally timed ultrasound. They have booked at third month, but almost like 25% of them do not have optimally timed ultrasound. This might be due to knowledge gap, or due to high patient burden, or long waiting time. The other reason to support the above knowledge gap or high patient burden for delayed ultrasound at health center is the fact that obstetric ultrasound is done for free in most health centers and government hospitals. So there is no financial issue. So there can be only patient burden or waiting time or knowledge gap. That's the only thing that we can identify when we see what factors affected. The other factors are those who had their first antenatal care at private health institutions and government hospitals are more likely to have optimally timed first prenatal ultrasound. This might be due to the fact that antenatal care is usually provided by obstetricians and senior physicians at these private and government institutions. This might be one of the factors. The other factor might be at private health institutions. There are, and at government hospitals, referral government hospitals, there are less number of patients coming for antenatal care because the majority of the mothers start their antenatal care at health centers, and they should be referred to have antenatal care at government institutions. So because of lesser number of patients at private institutions and government hospitals, that might be one of the reasons why these pregnant mothers have optimally timed ultrasound. The other factor may be at private hospitals and clinics, patients pay for ultrasound. So that means there can be some level of financial conflict of interest, because if the patients pay, then the physicians may order early and more number of ultrasound during the course of the pregnancy. So these are some of the factors which might explain why mothers having antenatal care at private institutions and government hospitals were more likely to have ultrasound. So knowledge gap and patient burden and possible financial conflict of interest in the private institutions may play some of the maybe some of the reasons why those having antenatal care at private institutions have optimally timed ultrasound. So the other obstetric factor which significantly affected the timing of first prenatal ultrasound is whether the woman had a previous major obstetric problem or not. So those women with major previous obstetric problem are more likely to have.
Sorry, Dr. Sisay, you might wind up.
Okay. I'm finishing. So this might be due to a pregnant woman with bad obstetric history may seek health care early in the next pregnancy. Other factors like parity, known health condition did not affect whether a woman would have optimally timed ultrasound or not. So this study has showed significant number, 1/3 of pregnant women do not have optimally timed ultrasound. So having regular antenatal care is not a guarantee for optimally timed first ultrasound, and the place of the first antenatal care affects timing of first prenatal ultrasound. So the larger multicenter studies should be done to analyze what other factors affect the timing for the first prenatal ultrasound. So the result of this and subsequent larger studies would dictate the policymakers how more pregnant women can utilize first optimally timed first ultrasound. Thank you.